I'm Pat Jenny. I'm president of the Salisbury Forum, and on behalf of the board, welcome all of you here to this beautiful auditorium at Housatonic Valley Regional High School, and this panel discussion on rural health care in the Northwest Corner of Connecticut. And let me also welcome you on behalf of the Berkshire-Taconic Community Foundation, which is our very generous co-sponsor for this program, and whose 4-county region includes the northern Litchfield County. Not only is access to healthcare a requirement for all of us, it also is often the largest sector of any local economy. It produces a lot of jobs, it produces career ladders, and it is a critical ingredient in making any place an attractive place to live. Our purpose this evening is to examine how rural healthcare differs from its counterparts in urban and metropolitan areas, and to describe what local health organizations are doing here to improve quality and accessibility. And now to our panel. We're very happy this evening to have a stellar group of experts to help us understand our local healthcare system. Nancy Heaton has been president and CEO of the Foundation for Community Health for 21 years, overseeing its grants, policies, and communications. Before joining the foundation, she served as executive director of the Northwestern Connecticut AIDS Project for 12 years, and earlier worked as a health educator in California and the Philippines. Nancy has served on various regional and statewide healthcare commissions in Connecticut. She received a Master of Public Health from San Jose State University and a BA from Lafayette College. Joanne Borduas, the next person in line, is the CEO and president of the Community Health and Wellness Center, the only federally qualified health center in Northwest Connecticut. During her long career, she has been a chief nursing officer, director of ambulatory services for an acute care hospital, and since joining the center, Joanne has expanded it from 1 to 3 sites, the third being the beautiful building, brand new building in Canaan. And she has increased school-based health centers in the Torrington and Region 1 school districts. She earned a bachelor's in nursing from Western Connecticut State and master's in nursing and MBA from University of Phoenix. Christina McCulloch was named president of Sharon Hospital in 2022, where she has been a leader since 2014, serving as Director of Nursing, Director of Quality and Performance Improvement, and Chief Quality Officer. Christina worked at several hospitals as a staff nurse earlier. She earned an MBA in Healthcare Management at Quinnipiac University and a Bachelor in Nursing also at Western Connecticut State. Meghan Kenny has served as Director of SVNA Home Assistance and the Litchfield County Home Assistance for 9 years. Both of these companies provide non-medical services from companionship to hospice respite. The two companies serve thousands of clients throughout Litchfield County, as well as the Farmington Valley, Southern Berkshire County, and Dutchess County in New York. She has a special interest in the aging process and has spoken locally and nationally on a wide range of aging issues. And last but not least, Maria Horn, who was elected to the Connecticut House of Representatives in 2018 from this district, is also joining us this evening. Representative Horn currently serves on the Energy and Technology and Environment Committees and chairs the Finance, Revenue, and Bonding Committee. Maria worked in corporate finance at JP Morgan before law school, after which she worked at a corporate law firm and then became an assistant U.S. attorney in the Southern District of New York before moving to Salisbury. Maria graduated from Princeton and University of Chicago Law School. So please join me in welcoming this panel.
Good evening, and thank you to the Salisbury Forum and the Berkshire-Taconic Community Foundation for hosting this event and inviting me to participate. So in an ideal world, everyone would have access to relatively local, affordable, and quality healthcare services across a full spectrum of care across one's entire lifespan, from prenatal to the end of life care. And those services would include things like preventive care, primary care, specialty care, emergency care, acute care, rehabilitation services, long-term care and supports, and the list goes on. And I forgot to mention that would also include the full span of behavioral health and oral health care services. Wouldn't that be nice, right? And we could spend our time here tonight discussing why this is not a reality for many in America today, regardless of where they live and how they live, but that is for another forum. Tonight, I will talk a little bit about some of the unique challenges and opportunities to providing and accessing healthcare services in our rural area. For starters, we just need to understand and recognize that what works in urban areas does not always translate into working in a rural area. Two of the main challenges of providing rural health care are low population base and travel distances. These two factors alone ensure that without innovation, each unit of rural service is likely to be more expensive to deliver than in an urban setting. Low population base is a bit self-explanatory. Most practices and facilities would build their budgets on predicting the numbers of, or projecting the number of patients and visits, and metrics can be, and these metrics can be hard to attain in a rural community, and in many cases may even close services because they can't meet their bottom line. But the most commonly cited unique challenge to providing rural care is transportation. But it's not just the lack of public transportation, which is the thing that's talked about the most. It also takes time to go to get to an appointment and to get back from the appointment, which means you lose time at work. Or conversely, maybe you're working with you're a visiting nurse or you're a home health aide, but your agency doesn't get paid for your travel time or distance in between things, and that hurts the ability of that organization to provide care. Having a good vehicle in good condition for both the patient and the provider is also important, as are road and weather conditions. But to get back to public, not emergency transportation, even on-demand programs like Gears Dial-A-Ride, I hope you've heard of it, can be complicated for some to access. And that service relies on raising money and being supported by a variety of sources like the towns, the individual donations, and philanthropy, and the state. Telehealth has been used to address some of these issues, but areas of poor or non-existent broadband and cell service are still issues today. And you may not think about this, but telehealth, while it has many benefits, one of the side effects for the transportation providers, unfortunately, means less rides, which means each ride is actually costs more per ride for transportation providers. And we've been supporting 3 different transportation providers for 20 years. And this is something that they've all mentioned. So it's a bit of a double-edged sword for us when it comes to our grantees. EMS services, emergency transportation, and their related paramedic services are often dependent or partially dependent on volunteers in our rural communities. But many EMS and fire services find it hard to recruit new and younger volunteers because there's limited options for work here, and housing and is expensive, making it difficult for younger generations to stay in the area and volunteer for these services. Conversely, rural health service providers are finding it difficult to hire. Granted, healthcare work shortages are sort of a national problem, but this is even more exaggerated in rural communities. It is hard to match urban setting pay scales, and as I mentioned before, housing is expensive and often difficult to find. It is also true that since most training takes place in urban areas, many of the newly minted providers do not even think about a rural alternative unless there's a program that introduces them to the idea of working in a rural community. Another major challenge involves reimbursement rates and payer mix. A reimbursement is what is actually collected as payment, for a service, and a payer is a private insurance plan or a public insurance plan like Medicaid or Medicare. And there may even be some self-pay people around still, especially those with high deductible plans, who might actually choose not to go to a service or even arrange a service. But missed appointments also cost money to the providers, and so that can often be an issue. As mentioned before, it is often more expensive to deliver the unit of care in a rural setting. And in this case, with the payers, regardless of what payer it is, each has negotiated a specific rate. And many of those rates are probably based on larger pools, and it is not likely that they take the ruralness of an area into consideration when they're coming up with those rates. There are some government programs and designations that do help boost either rural hospital reimbursement costs, like Critical Access Hospital or the sole community hospital status, which I do believe Sharon Hospital has. And FQHCs, federally funded health centers, like the Community Health and Wellness, in theory, are supposed to be made whole for every Medicaid visit, meaning the rate per visit is supposed to reflect the actual cost of care. I said in theory, and I'm sure Joanne will talk about this, and we'll elaborate a little bit more about this later. In short, however, these reimbursement rates have really not kept up with costs, and our providers are hurting. Complicating things in our area is the fact that we're also on the border with 2 other states. And Medicaid specifically is a state and federal partnership, meaning that each state can make a different set of rules, different payment rates, etc. Making it hard for those individuals who are on Medicaid to move in between state lines for services and for the provider to actually collect payment for their services. This was something new to me, so I thought I'd add it here. Recent studies also point to the fact that the uptake in electing Medicare Advantage plans among those eligible has actually contributed to rural hospital closures across the United States. Rural areas as a whole, and that is true here, have older and often more sick populations, and therefore have more Medicaid as a primary payer for medical services. Apparently, Medicare Advantage plans typically negotiate lower reimbursement rates. Another factor that supports this also is that in many states, they elected not to expand Medicaid as part of the Affordable Care Act. And of the 200 rural hospitals that have closed, most of them have been in those states. Luckily, Connecticut was the very first state actually to sign on to the expanded Medicaid. But it is estimated that today, nearly a third of the remaining 700 rural hospitals are at risk of closing, and a lot of them for the reasons that I've already talked about. So I was going to tell a more positive story after this, but I've decided I've talked too much. So while I believe that I get excited and believe that rural health services can be creative and innovative and flexible and successful and cost effective if we work together as a community. I also am a realist and believe that without local government, local state and federal government playing a critical role in the in helping to make sure that services exist in rural communities, that we're all at risk of losing services. And so, with that, you should really have an opportunity to hear from those who are actually doing the work on the ground here today. And so I'm going to now turn to each one of you, and I will sit down after this, and ask you each to briefly describe the specific role of your institution in the Northwest Corner's healthcare delivery system. So you're going to start with Joanne.
Good evening, everyone. Thanks so much for being here. As Nancy said, we have an organization, you may have heard of it in North Canaan. It's fairly new since last July, Community Health and Wellness Center. It is one of 3 locations that we have. Our main center is located in Torrington with an additional site in Winstead. The story of us getting to North Canaan is about 20 years long. And so we are so excited to finally be here and be a part of this amazing community and further north from where we are in Torrington. I was driving up here tonight and it is just peaceful, beautiful, and we're so grateful to be here in this neighborhood. What do? We are a federally qualified health center, otherwise known as an FQHC. I'm going to try to stay away from acronyms. but that, if you've heard the term FQHC, that is who we are. There are 17 FQHCs in the state of Connecticut, ranging all the way down to the eastern part of the state to all the way here in the Northwest Corner. As FQHCs, we are federally funded by the government, and we are funded through a branch of the government called HRSA, Health Resources and Services Administration. How much of that funds our operations depends on size, volume, and services for each of us. We offer comprehensive care to our patients, and we look at patients holistically. So we're not just treating them for their medical care, we're not just treating them for their mental health care, we're treating them as a whole. So in addition to primary care, mental health, and dental in some of our locations, we are also providing what are called wraparound services or enabling services to patients, which sets us apart a little bit from private practice. And what that means is you can walk into our center and you could ask for a community health worker who will sit and take the time with you if you are, for example, uninsured. Most folks are uninsured because navigating our health system and trying to get insured is very difficult. And so in addition to coming in for your medical appointment, we'll have a community health worker sit with you and determine whether or not you are actually eligible for insurance. If you need things like vouchers for transportation, we know that transportation here is a problem, and we do need to send folks for specialist referrals. Distance travel here in the Northwest Corner is a problem. It's one of those barriers that we experience, and it's one of those things that we'd like to assist folks with so we can close gaps in care. So we can help with those things. We pride ourselves in not staying within the four walls of our organization, but actually doing a lot of outreach in the community and collaborating with our community partners, because the reality is we cannot do everything alone, and we need our partners to do those things that you will not find in our health center. I do want to say we are not in urgent care. I know that this area probably really needs one, and hopefully someday, as Nancy's alluded to, we can get all those comprehensive services that are still a need here. But in order to establish with our center, you do need to come in, transition your care, or be established as a new patient, and then we are happy to see you anytime you need us. So our primary services, again, are primary care, mental health. We have a chiropractor that is in the North Canaan location as well as in Torrington. Happy to report that she's getting very busy and that we may increase her hours to 2 days instead of 1 day, which is great. We've been open here since July, and we've already seen 800 patients. And that's a lot of patients coming through our doors, which just demonstrates the great need here in this community, and we hope to continue to service and meet the needs at large. In addition to our chiropractor, you can also come in and ask to see our nutritionist. Our nutritionist helps with healthy lifestyle and healthy eating, because that is an important part of caring for chronic conditions. We have lots of folks who come in and say, you know, I have high blood pressure, but I really want to stop taking this medication. And so we offer alternatives to that. So our services, again, are offered in a comprehensive, integrated manner. Our providers speak to one another because we're not just treating from the head up or the neck down, depending on what you're coming in for. We're treating the patient holistically. And our providers can see patients from beginning to end of life. Most of our APRNs are family practice. We are happy to announce that we will soon have Dr. Humphreys, who's actually here with us in the audience. She just started this week, so welcome, Sarah. We're very excited to have Sarah on board. Thank you. So we will soon, you will be seeing her face, and we will put her out there as your community doctor, which folks have really been waiting for. So we're very excited to have Sarah on board. She's not quite seeing patients yet, but in the next few weeks or so, she will have a schedule opened, and all you need to do is call our location and we will get you set up. So that is what we do at Community Health and Wellness Center. We take everyone that walks through our doors. Nancy alluded to folks who are on Medicaid, who are uninsured. We take anyone. It doesn't matter what kind of insurance you have, whether it's commercial, Medicaid, Medicare, or no insurance. If you are uninsured, we will sit with you and help you to afford your care, because our goal and our mission is founded in providing high access to quality care and to making sure we are there to service your needs. So we hope that if you need us, you come by. We're happy to set up an appointment for you, or even just come by. The facility is beautiful. We're happy to give you a tour. And that's a little bit about us.
Good evening. My name is Christina McCulloch, and as mentioned, I'm the president of Sharon Hospital. And I'm honored to be here tonight to talk on behalf of the hospital with all of you. So Sharon Hospital, if you're not familiar with it, is a small community hospital tucked away in this beautiful Northwest Corner. We're located in the town of Sharon, although we do serve patients from Connecticut, New York, and a little bit of Massachusetts, I'm sure like many of my partners up here. We are part of a larger healthcare system called Nuvance Health. Nuvance Health is a 7-hospital system located in Connecticut and New York. It's also comprised of many medical practices and outpatient settings as well. A little bit about the hospital. We are, I like to think, a very critical and vital part of the healthcare community here in the Northwest Corner. We're one of the larger employers in the area, and we provide a wide range of services related to healthcare for those in our community. We see 13,000 patients every year in our emergency department. We see close to 40,000 patients for outpatient visits. And outpatient visits are anything from coming in and getting your blood work drawn, coming in and having an x-ray, a CAT scan, an MRI. We have rehab services, physical therapy, occupational therapy, speech therapy, a wound care center. So those are just some of the outpatient services that we offer. We have close to 1,500 patients that are admitted to our hospital each year. So those patients are requiring an overnight stay for treatment of some sort of acute illness. And when we look at our procedural and surgical volume, we do about 2,000 surgeries and procedures every year. So a lot of work going on at the hospital to serve the community. As mentioned, I've been at Sharon Hospital for 10 years in a variety of roles, and I want to share what I'm most proud of about the hospital. And that's the people that work at the hospital and the care that we give. If you don't know, we give excellent personalized care. We have really exceptional patient outcomes, meaning when you come to get treatment for whatever it is you're seeking treatment for, you leave better than when you came. We have received the 5-star award. That doesn't happen everywhere. We've received a 5-star CMS award for 5 years in a row. Last year, the only hospital in the state of Connecticut to be a CMS 5-star hospital, something we're extremely proud of. We're a Leapfrog Grade A hospital. We're a primary stroke center. We've received gold awards from the American Heart Association and many more awards from Health Grades. And I share this with you because of all of the struggles that we're going to share about delivering health care in this rural community that we're all in. We're able to do it really well. And it's really important to be able to do that. So I look forward to discussion for the remainder of the evening. Thank you.
Megan?
Hi there. My name is Meghan Kenny, and I'm the director of SVNA Home Assistance and Litchfield County Home Assistance, both of which are private duty, non-medical companies. Our goal is to provide those within our community hourly help and allow you to age at home or even within a rehab setting or facility, depending on your needs. We help clients anywhere from making a home-cooked meal, offering companionship. We do transportation, and then we go through personal care needs and end-of-life needs. We started out in these little communities, the 6 little towns. When I started, we had 20 clients. And 9 years later, we've got about 150 clients combined, and we serve through Farmington Valley, Southern Berkshire County, as well as Dutchess County, New York. Both companies have the same goal, just different models, which allows you to pick the model that fits best with your lifestyle. For a lot of people, that's the financial end of it. So it allows for some choice in the same goal of keeping you home. We are directly affiliated with what is now Visiting Nurse and Hospice of Litchfield County, which bear with me because I'm going to explain how that came to be, which can be kind of a spider web. So, as most of you know, we had Salisbury Visiting Nurse Association here, and they served wonderfully for over 100 years in our little towns. But we came to realize that remaining an independent VNA becomes really difficult with managed care. And so we saw that over 50% of people 65 plus were getting the Medicare managed plan, and unfortunately, that made our reimbursement rates less than the cost of providing a patient actual care. So we had to get creative. We wanted to remain personal, small, and we wanted to work with a company that had the same values and mission statement, and we went right to Foothills. They served the similar locations, we had the same mission, similar missions, similar values, and so we decided to join forces. And part of the reason why also is because the Department of Health requires that within each VNA you have to have specific roles, director roles, administrator roles, quality care, and there was a duplication there, both in the towns that we were serving, but also with the roles. So we decided to become one, and it has allowed us to remain competitive with the for-profit and the larger agencies that are around us. And it's been so successful that we also have joined teams with the Farmington Valley VNA. So we work directly with those nurses, and it allows for a wonderful continuity of care. The VNA has physical therapists, occupational therapists, speech therapists, RNs, and we offer an abundance amount of programs that are free to the community that allows us to get to know you, and we've been able to remain personal and small. So that's a little bit about us.
Maria?
Thank you. So of this esteemed panel, I'm the layperson. I can, like all of you in the audience here, I am a consumer of all the incredibly important services here, which run the gamut from, blood work to surgery at Sharon Hospital, not to mention time logged in the emergency room with our 3 kids, which my husband and I can tell. And SVNA helped me care for my mom at the end of her life, and I'm deeply grateful for that. And just today, I was at the FQHC in Canaan with a primary care appointment, and I believe my nurse is in the audience. So my role, in part, comes from the fact that I chair the Finance Committee, and I spent a lot of time talking to the Public Health Committee because the chair is a close friend of mine, and we're paying attention to what we can do. So on the sort of the challenges front, Nancy alluded to this, Medicaid reimbursements. Absent even what's now happening or threatening to happen at the federal level, Connecticut's reimbursements are really low, and embarrassingly low. I will use that adjective. I think no one here will disagree with me. At a time when we're, of course, one of the more expensive states in the country. And we, I think, this year had arrived at a critical, agreement amongst many of us that it was time to stop trying for everything and to try to address that this year. But that was depending on how you calculated, $200 to $400 million initiative in Connecticut to try to get those rates up to something that approximates the actual cost of care. That, of course, is, in this moment of time, we're also running a lot of numbers about what is threatening to happen at the federal level, and that, as we calculated today, Connecticut will likely lose somewhere between $1 billion and $2 billion in Medicaid payments from the federal government. So that's a big deal. I mean, that is, 1 in 4 people in the state of Connecticut are served by Medicaid services, and in terms of long-term care, that's what's paying for long-term care for many people in our senior relatives in nursing homes. So that's a serious thing, and we're sort of, as we craft a budget this year, we're we're trying to sort of manage the things that are in front of us with an eye toward, shadow boxing against what might happen at the federal level, trying to come up with big picture alternatives and talking to other states in terms of how they're going to address that. In terms of what we're dealing with this year, I mean, part of that, the challenge of rural healthcare has to do with our costs here. It is the cost of housing, and so it's things like supporting local affordable housing initiatives, which we're finding creative ways to do because our costs here tend to be higher than per unit costs tend to be higher than in other parts of the state, and so we have to use multiple funding sources, which we've been able to do. Sources from the Department of Housing and also other being a little creative about adding enough to that to get us to able to actually create more affordable housing in the state, in the region. We're also working on loan reimbursement programs for healthcare professionals, and just today the Public Health Committee voted out a bill that would strengthen loan reimbursement programs, and it is specifically focused on primary care, FQHCs, and rural healthcare providers. So those are the 3 areas of practice that are specifically named in that bill because we know that that's an area of need. We're also looking at broadband. Just today, this is a version of a conversation that I had today in another space, the environmental space, but we create various grant programs in the state to try to, alleviate infrastructural or cost needs in various parts of the state, and they're often, they're not funded 100%. We put a pocket of money in there, and then it's a competitive program. And what has happened in the past is, because it's a competitive program, they go to denser parts of the state because they can have more impact there. So just today, I had this conversation with both health officials and the Department of Energy and Environmental Protection about when we set up those grant programs, we absolutely have to correct for the fact that if you are in theory serving all of the state and the rural parts of the state, we need to make sure that we're not lopping off all the small towns here, because if density is part of your calculation, I just used this expression today, you have just lopped off the entire Northwest Corner. After which I got a call from the commissioner saying, we're not going to do that, we're sorry, we're going to work on that. So, but it's the kind of thing, and that's true in the broadband space, it's true of various things the state does. I think there is an awareness of the need, cost needs, affordable housing, broadband, workforce retention, all of those things focused on rural areas of the state like the Northwest Corner. So I think we're paying attention to it, but we certainly have plenty of challenges ahead of us.
Joanne, I mentioned or alluded before, and Maria's already talked about it, so talk a little bit more about the Medicaid issue in particular for the FQHC.
Yeah, thank you. So I mentioned earlier that we see patients that walk through our doors who are uninsured, who have Medicaid, Medicare, commercial insurance. We basically don't turn anyone away. As FQHCs in the state of Connecticut, last year we saw 440,000 patients among our network. 60% of those patients, or 265,000, are beneficiaries of Medicaid. For community health and wellness, the statistics are similar. 60% of our patient base that comes through our door are Medicaid enrollees. That is because as an FQHC, when we have that designation, we have an obligation with the state and the state Medicaid program to make sure that we provide access to patients who have Medicaid, patients who are uninsured, and that may be, as Nancy stated earlier, it might be because patients have commercial insurance with high deductibles. But Medicaid is definitely very concerning for us. Community health and wellness sees 6,700 patients last year. That has been an increase of 13% since 2023. And again, 60% of those patients are Medicaid. Now, what will happen if Medicaid is impacted? It will mean that it is unlikely that those patients are going to be able to receive services elsewhere, because private practices don't have that same obligation to take 60% of Medicaid patients. They can say, I think maybe I can only take 2 this month. And that is because of the very real issue that Connecticut is very underfunded when it comes to Medicaid. Compared to our neighboring states, Massachusetts, Rhode Island, New York, we are paid 30% less on average than those states are with their Medicaid rates. And the reason it's concerning is at the federal level, if Medicaid is impacted with the numbers that are being put out there, and Maria just validated some more concrete numbers, there is a thing called a match that happens at the state local level. So let's just say 50% from federal, 50% from state is what funds our state's Medicaid program. If those federal dollars go away, it is inevitable that our state Medicaid program has to make some drastic changes. If that happens, those providers they are funding to help us take care of patients who are on Medicaid, to help us provide that quality access, is going to be drastically impacted. I mentioned earlier that we go outside of our walls, and one of the ways we do that is we also have 10 school-based health centers. 7 of those are located in the Torrington School District, and 3 are right here in the Region 1 district, this being one of them, Sharon Central and North Canaan Elementary, and we provide primary care and mental health at those sites. Those practitioners are funded by federal grants. So if federal grants go away, we have a really big problem trying to continue those programs. We have a big problem trying to maintain access to patients who are on Medicaid seeking care. And the ripple effect of that is going to be that Christina's ER is going to be filled with patients who have waited to receive care because they can't afford it in a normal setting. They have waited, they are going to be sicker, they have not been compliant with their medications, and so Christina will see them in her ER, and it's likely that those patients will be admitted. The impact of that is poor patient outcomes, population health will decline. The impact will also be that while we're all striving to curtail costs for primary care and bring those costs down in Connecticut, we are going to actually do quite the opposite and increase costs to the health system, because those patients are now going to increase uncompensated care for the hospital. So it is a crisis that starts there. Many programs may be impacted. Some FQHCs have already closed services. I will share with you that in our Torrington and Winstead offices, we were providing dental care. As of February 28th, we could no longer do that. That is because of the looming uncertainty around grants. 60% of our patients receiving dental services were those patients who were covered by Medicaid. Workforce issues, trying to recruit, and salaries have gone beyond what a nonprofit can afford. And dental procedures, as you all probably know, if you're going for dentures, a root canal, a crown, a bridge, those things can be very expensive, and most of the time insurances, including commercial insurance, does not cover full costs, and you're left with a balance. Well, for Medicaid patients, we don't balance bill them. So what we do is we write off those costs for the balance of what we get paid. And I'll give you a quick example. Dental costs us $240 per patient to be able to provide that service. Medicaid is paying us $170, one flat rate. So it's impossible from a service perspective and a business perspective to maintain those services and sustain, but it's the effect of that ends up being to patients who now need oral health care elsewhere in a part of the state where we can't get them there very easily because of the barrier to transportation. And oral health is just as much a part of well-being as is getting your primary care or your mental health services. So those kinds of things are the very real impact to cuts to Medicaid program. It will impact our safety net providers, being FQHCs in many of the communities we serve, and it will impact patients' lives, and in some circumstances, that is truly life or death.
Christina, do you want to talk about the impact on the hospital then?
Sure, I'd love to. So there are many challenges that the hospital experiences, and I'll say one of the overarching themes is financial instability. And unique to rural hospitals, there are a couple of things that lead to that. Simply stating the cost to run a hospital is more than the revenue we receive from the patients that we see, and so that creates a negative balance, right? And so that leads us to having to make certain decisions on what services we can provide. So when we examine our community and look at what services do our community members need most, and try to strategize and make decisions like that. We also see many challenges related to the population and the low volumes, because when we're trying to provide certain services, you need a volume of patients to be able to sustain that service. That leads into recruitment of providers. We're trying to bring in a doctor to our community. We need to have enough patients for that doctor to have a sustainable practice. And that's been a challenge in certain areas. And so we've had to think creatively and innovatively. Where can we look to share providers with other communities so they can have a robust practice? We have leveraged telemedicine a great deal. And while we always use telemedicine, in the past, I'd say 10 years or so, during the pandemic, we were forced to. And now there are many programs that we rely on for telemedicine. I talked to you about our award-winning stroke program. Well, our program is based on telemedicine. When you come in, if you're having a stroke in our emergency room, we get a neurologist to see you immediately, within minutes, faster than if we had a live neurologist coming into the hospital. And that's all done through telemedicine. We have equipment that can do an assessment on a patient, examining as close to your pupil, looking at your respirations. We have the technology to be able to do that. But that's all new and different and innovative ways to provide care to our community because of some of the challenges we have with recruitment. When we look at the overall workforce of the hospital, certainly we struggle with attracting people to work at our hospital and retaining people that come to work at our hospital. And not necessarily the people that live in our community and have family and friends here. We have a lot of longevity in the staff at our hospital, but it's others where you're trying to bring from other communities because there aren't enough people that live in our small community to fill all of those positions in our hospital. The workforce of a hospital is large. There are medical professionals, we have doctors, we have nurse practitioners, we have nurses, which are the largest group of staff at our hospital, respiratory therapists, but there are also finance people, human resources, environmental services, facilities workers, really a wide range of careers available at the hospital. And again, we've really had to think out of the box and innovatively and learn from some of our peers across the state and across the nation to say, what are people doing to either build their own workforce or to retain? If we look at nursing, which is the largest number of people we have in our hospital, we've done things such as residency programs and fellowship programs. And what these are their programs designed for either new graduate nurses that want to work in the hospital or a nurse that wants to work in a specialty field such as the operating room. And they're programs that are designed for that nurse to work with a cohort of nurses just like them, to have support through education and seminars, but over a long period of time, up to a year. We keep these nurses in these programs, and it's really helped with some of the retention just by having that support there. We've also really started branching out into the community to see how we can create pipelines for workforce. We have started a high school immersion program, and we're constantly doing shadowing with high school students, and honestly, we love it just as much as the high school students do. Just the teaching and learning and relationships we've created, and we have hired high school students from these programs, so we're finding great benefit in that. Yeah, so that's I think.
Great, thank you.
That's all.
Megan, you had some concerns that we talked about.
Yeah, absolutely. So, you know, obviously there's challenges in all of our fields, and I think for me, specifically with my two companies, is retention of employees. And that's right now the reason why it's more difficult is lack of affordable housing. You know, I know that there's a lot of pushback within these small communities to not have those affordable housing units come into play. There are concerns about how it will change our community as a whole. However, I'll give you a quick story. This afternoon, I had somebody locally within our 6 towns call me and said, I need immediate service. I need 3 hours in the morning, 3 hours in the evening. I need help in the bathroom, in the shower, and oh, by the way, I want my caregiver to be local. We did it, but I will say it is becoming more and more common for a caregiver who has worked for me or the company for a long time to call and say, Megan, my landlord just gave me a notice. They're putting the house on the market. There's nowhere to live. The wait lists for affordable housing are astronomical. Unfortunately, I have to leave. A lot of them head south. The ones who head towards Torrington, Winstead, their client just lost them because they don't want to drive, you know, in the winter or in general to this area. So I became a huge advocate of the affordable housing initiative because they are the people who are going to be taking care of all of us. And, you know, they deserve the right and the ability to have affordable housing. They do not get paid enough. They do some of the hardest work. I couldn't do it. So that's a huge issue that I'm a very big advocate of. There's also a lot of resources in Connecticut that are incredible, that do provide funding to our agency, one of which is the Veterans Association. I just became affiliated with them last year, and they see clients and they will approve a certain amount of hours. Some get 4 hours a week, some get 80 hours a week, and we are able to go in and provide them care. The biggest issue with this is that, unfortunately, they require in-person visits in order to qualify and get that referral. They're in West Haven. That's an hour and a half away. 2 issues. First of all, transportation. Yes, can we provide it? Absolutely. But it's making sure that, you know, that's a cost as well. And we mentioned cars. You know, you got to make sure you have an adequate car for somebody who might have a disability. We got to make sure that they're covered under workers' comp. It's costly. But also, sitting in a car for an hour and a half, one way, for somebody who's aging is not easy. Let alone, I just had a client who, he served our country. He deserves this benefit. He's homebound. He cannot get into a vehicle. And they do not allow for any of this to happen over telehealth. It has to be in person. So unfortunately, the family had to decline, you know, taking on that benefit and paying privately because they couldn't get him in the car. And, you know, one of the top things that I am working on is becoming an advocate. I appreciate the Veterans Association. They do incredible work. But, you know, they need to think about us in these little towns and know it is not easy to drive an hour and a half one way and come back, especially if you're aging. And it's impossible if you're homebound. So, you know, that is a big organization that I have been hounding because I want to get it so that our clients can take a telehealth and get this referral, and then they get the funding for our program. So that's just one of 2 challenges, but the biggest ones that I see today.
Thank you. Joanne, you were going to share some statistics that you
Yeah, I wanted to share some statistics with you, just again to resonate that while we have a rural healthcare crisis, it is a product of a larger national crisis. It starts there, and it is mostly felt in the rural areas. I would say, probably 2 to 3 times, if not more, greater than with our urban counterparts, because they're not facing the same challenges. There's public transportation, there's more density, there's more available specialists. So the impact in the rural areas is really felt from something that starts nationally. But just some facts to share with you. It is projected through the American Medical Association that by 2036, the nation is going to face a shortage of primary care providers that equal up to as many as 87,000 physicians. So how do we help somebody like Meghan was describing about aging at home and getting providers and getting folks to doctor's offices when we're going to be short 87,000 physicians? That is because we're seeing very low rates of enrollment into primary care or internal medicine. Most medical students are opting to take the specialty track. And why is that? It's because as a primary care provider, there is a factor called burnout. When you have less resources in an area like ours, you're working much harder to make sure we meet the needs of the community. And so the most recent statistic is that only 2 to 4% of medical students from rural areas have enrolled into primary care medicine. That's really alarming if we think about the future. Some other consequences of all of these challenging barriers in rural areas is that we see increased prevalence of chronic disease. Why is that? Because we can't get folks to their doctors, and they won't go until they're very sick. And so just some statistics around that. In urban areas, for example, you can have 263 specialists for every available 100,000 residents. In a rural area, that number comes down to 30 specialists for every 100,000 residents. 65% of rural communities have shortages of primary care. And again, only 4 to 5% of rural people are expected to enroll into medical school. So that is very concerning for our future. And it is with partners like we have here tonight that we work together to make sure that we meet the needs that are necessary. It is with folks like Maria who are advocating, and I would encourage that when there are issues around advocacy that everyone has a voice, because we are stronger together. And policy changes do happen, I can vouch for that. And so that is the way that we fix this in our rural areas. One of the strongest ways is to advocate and to come together.
Thanks, Joanne. I just want to make a plug also for, I've worked in this area for 34 years now or something like that. And what's been the most exciting and successful and rewarding to me just in the work that I've done over the years is that when it happens, when people do work together, when the organizations recognize that supporting each other and working together produces much more than the sum of their work, and it's a beautiful thing. And I don't think it happens as much sometimes in the urban area. It's required really for anything to be done successfully here. And that's the only way we're going to really also work on what we call the social determinants of health and make sure that there's more prevention just in the fact that the food pantries know where you are, you know how to refer people to the food pantries, or your relationship with the VA, that those kinds of connections, right down to all kinds of human service providers. Only when we really work together can we really come up with a system that's innovative, flexible, and unique. Unfortunately, we do need the federal and the state governments to assist us, and there lies the rub at the moment. So I have here questions that have been posed by the audience, so I'm going to read off them. The first question here, has a community needs assessment been completed in the Northwest Corner recently? And Christina, you might mention what's happening at the hospital?
Yes, we just completed a community health needs assessment. So Sharon Hospital, along with our community partners, we do perform this assessment every 3 years. We did just complete our assessment, and through our community health committee,
Of which I'm a member.
Yeah, both Joanne and Nancy do sit on our hospital community health committee. We're going through what we've obtained through the survey. Is there are interviews for community members to provide us information. We also look at market data and some other sources of obtaining information. But what we do is we gather all of that, and then we prioritize the needs of the community from our community. What are you saying the needs of our community are? And we compare that to what we're seeing in the market and what we're seeing in our health centers. And then what we do is we prioritize that and we create action plans. So we say behavioral health is a priority every year, and it is. So what are we going to do about it? And what we're doing isn't working because it keeps coming up each and every year. So how do we do this better? Food security is another one that pops up on our assessment. So how can we work together, and that's what we do through this community health committee, to solve the issues that our community are telling us they're facing.
Thank you. Another question here. Why is the reimbursement for Medicaid 30% less than in other states around us?
Yeah, that's a great question.
Does Maria know the answer?
So I don't, part of the answer, it's obviously a complicated question. I've had this conversation with various people since I've been in office. One of the problems recently is that we've had a lot of conversations about, I don't want to put a label on people, but some of my more progressive colleagues in good faith have argued we should expand the base. More people should be covered. For example, we cover immigrant children. And we have proposals every year to have it, you will see advocacy at the Capitol for Husky for All. Husky is Connecticut's Medicaid program. So expanding the base, lots of arguments about expanding the base to more people, and it's because those have been difficult conversations. I believe we have punted on the real issue, which is that we need to increase the rates for the people we do cover and make sure that we're actually covering the cost of Medicaid before we seek to expand it. I'm happy to have those conversations, but I do think that this year we had a critical mass of leaders in the General Assembly who were ready to make that commitment. We have a lot of challenges, as I said, but how we got here, I don't know. I've had conversations with the governor about it, and who has claimed to me that actually the state's Medicaid expenditures overall are quite high. So there's some structural challenges here, even though our reimbursement rates are low.
Joanne, do you want to add?
Yeah. Joanne?
Yeah. So there is a bit. I'm the head of the what?
She is the president
CHCI?
of the Community Health
So,
the Community Health Center Association
Yes,
for
thank
Connecticut.
you.
So she knows her stuff.
Yeah, thank you. And the association is one that governs all of the federal qualified health centers in the state. And yes, thank you. I do sit on that board as the president and chair. There is a little bit of a history with Medicaid to help answer that in terms of the FQHCs and why we are so low in terms of the rates. And it really is because for 24 years, we have not been rebased, I will call it, in terms of looking at those costs versus what we get paid. So the last time that actually happened was back in 2001, and that was based on 1999 and 2000 costs. So here we are in 2024. We had this thing called the pandemic, which made things go crazy, and wages and all kinds of economic inflation. And we have a process that should happen. Some of it is written into federal law, so that when our costs go up, we should be able to submit to the state to let them know that, and then incrementally those costs should get adjusted and to our rates. But that process is a bit flawed, and that is kind of the history for the FQHCs. Now there's a very simple, I think in my mind, I always say it's simple. How do we expand access to health care for Medicaid providers? And I do believe that our legislators are supportive of increasing Medicaid rates, because we know Connecticut is lagging behind. But the simple answer is we need to increase Medicaid rates for all primary care providers, because that will expand our network. So that takes a little bit from me, right? But my goal is to make sure that patients get seen. That's all of our goals. It's why we go into medicine. It's why we do what we do. And in the end, that is going to be the only contributing factor that helps our patient outcomes. So if we take a look at every primary care provider in the state and everybody gets their Medicaid rates increased, so it's feasible from a private practice perspective even to see Medicaid patients, that's a simple solution that I know is easier said than done, but that is really what we need to do. We need to expand Medicaid providers to receive rates. We do get paid as an FQHC because we have this obligation with the state to see a large percentage of Medicaid patients. Our rates are better than a private practice, but they're not at cost, and that still becomes problematic.
Thank you. I have a question for Megan. It says here, how do you attract and retain your non-medical care professionals? And then it says affordable housing, question mark.
Yeah, so I mean, we kind of touched on this, but one of the things we've also worked on is getting benefits for our employees. When I started, we had none. In 2020, I started to look at how we can realistically offer benefits so that we can retain our employees, and if even better, take on more. And I was able to create a paid time off program that allowed them to have 2 weeks of vacation time. They work hard enough, they deserve it. And I'm very excited and proud to say that this year we've had enough growth where the Department of Labor says we have to offer medical insurance, but it's been a huge, huge success for us. We have employees who actually for the first time are coming back to us because now we're offering benefits such as medical insurance, PTO, and we try really hard to stay competitive with the pay rates. We also really try to focus on the employees' needs. If they only want to drive 15 minutes away, we're not going to push them, because if you push them, they're not going to go to work. So we make a point to know every single one of our employees and what their preferences are in regards to work life and work shifts and what they're able to do. And it's been a little easier, but again, the affordable housing would allow us to provide care for far more people who need it, specifically in these towns, and they deserve that.
Thank you. This question is, I guess, for the medical providers here. Have you witnessed or dealt with the discrepancy in medical care between genders in your practices? And how does this issue compare to urban areas? I'm taking from the blank stares that it's not an issue, but maybe talk about it.
I think maybe just to clarify, so in our health center, we do care for patients who may be coming in and seeking, for example, gender-affirming care. I don't know if that's really what the question is relating to, but our practitioners come with a range of background. So not only do we treat those folks in the primary care setting, but many times they are also being treated in our behavioral health area as well. So if I'm answering the question, at least for community health and wellness, we do have experts who we employ who do treat folks seeking gender-affirming care. It's unfortunate that some of that may also be impacted with the current environment, but we are going to continue to do what we do as our mission, and that is embedded in treating folks for whatever their needs are that come through our doors.
And I can add, it's similar in the hospital setting. we do care for everyone that comes through our doors, and we do try to tailor that care to the individual. We do have a health equity and diversity program. All of the staff at the hospital are trained how to appropriately treat each person as an individual. So it's something that's very important to us.
I hope that answers the question. The next question is for you, Joanne. It says, what services does the FQHC have for substance abuse disorder clients?
Thank you. So what we do is something called MAT therapy, or medication-assisted therapy. Some years back, that used to require that our providers needed to go and get certified for that. They had to attend a certain number of hours to be able to get certified in doing that. Over the last 5 years, that is no longer the case. Any primary care office can actually see folks coming in for medication-assisted therapy. So we do the same. If a patient comes in and tells us that they need help with addiction, we offer oral assistance with that addiction, and then we also coordinate care in our behavioral health department, because oftentimes there are underlying issues to addiction that need to be addressed as a whole. And thank you for bringing this up, because I do want to clarify, we are not a methadone clinic. I know that that question has come up in the past, similar to, are you in urgent care? So we are not a methadone clinic. You do need special licensing for that. But like every other primary care office, we treat substance use disorder collaboratively between our primary care providers and our mental health providers with oral medication.
Same person asked, is Sharon Hospital a full stroke center facility?
Yes, so Sharon Hospital is what we call a primary stroke center. So any patient having a stroke can come to Sharon Hospital. We will assess you, we will treat you outside of any intervention needed. So if you need an invasive procedure, which is a procedure that's done to remove the clot, if you've had a clot that's causing your stroke, those are procedures we don't do at Sharon Hospital, but it is important if you are having symptoms of a stroke to come to your nearest healthcare facility, because we can assess you, we can treat you, and we can stabilize you to get to you quickly to the appropriate facility if you do need an intervention, which everybody does not. But we are a primary stroke center certified through, there's an accreditation agency called the Joint Commission. You may have heard from them. They come out routinely and do a full assessment of our program to ensure that we meet all of the safety and quality standards before giving us that accreditation. And as I mentioned before, the American Heart Association has recognized the hospital stroke program. They've given us the Gold Plus Award, which is the highest award you can receive. But basically what that means is we are delivering standard of care for stroke patients. It's evidence-based care that's done around the nation. And our outcomes for our stroke patients are very good. Meaning, again, you come to the hospital, you receive the right treatment, and you leave well.
Thank you. This question is, first they talk about the potential closing of the Sharon Pharmacy and the potential sale of a CVS. But the main question is, are we losing our pharmacies, and do we have any solutions to that? And I don't know, Joanne, or...
I'll speak to just quickly some of the things we do with pharmacy. Again, it's a benefit of being a patient at a community health center. We participate in a federal program, so hopefully there will not be an impact there. But our patients can receive medications at deeply discounted prices through something called a 340B program. Those are usually contracted services with pharmacies, so we do have a pharmacy on site in Torrington, and that pharmacy does allow us to participate in a 340B program, but what we also do is contract out with any pharmacy in the community that participates. An example, if somebody is diabetic and needs insulin, if you don't participate in the 340B because you don't qualify, with your insurance plan, you can pay, say, $800. It's pretty expensive insulin and pens. through a 340B program, you can sometimes get those medications at a cost of about $20 to $30. So we do what we can to participate with as many pharmacies as possible so that our patients are able to afford their medications, and most of those services for us are contracted.
I do not know what is happening with the Sharon Pharmacy.
I don't have that information either, but
I live in Sharon, I haven't heard it, and I hear most things, so.
I will just add that I do know that independent pharmacies are seriously threatened. There's no question about that. And that we have had, and I'm not certain of what we're looking at this year, but legislation with better regulating the pharmacy benefit managers, who are effectively the sort of middlemen between the hospitals and the patient. And the system was created in order to make it more efficient, but it has exploded and a lot of the money has been sucked out of the system into the pharmacy benefit managers. I'm not certain whether we have legislation this year. This is something that really needs to be handled at a federal level as usual, but we usually do try in Connecticut to at least tackle, aim it at it a little bit. I'm not sure what we're doing this year.
thank you. I went to a conference one time, and actually it was something like Nebraska or somewhere in the middle where there wasn't a lot of anything, and there was a foundation that had founded like ATM machine they were like ATM machine pharmacies because there was there were no pharmacies for hundreds and hundreds of miles. So people have been trying to think about that for a while in much more rural areas than here. This question is for me. So, what does the Foundation for Community Health actually do, and how does it interact with Sharon Hospital? So very briefly, we were created when Sharon Hospital in 2003 was sold to a for-profit entity. So according to nonprofit law, the monies from a nonprofit, and Sharon Hospital was a nonprofit at the time, have to stay with the same purpose. So they have to go to an organization with the same purpose. And the state of Connecticut, in all its wisdom, decided to create a foundation to put the monies from the sale of the assets. And it was primarily unrestricted funds around the sale of the assets. So we do have a couple of donor advised funds that came over from the hospital, but basically the bulk of the funds that had come over were unrestricted and without purpose and unendowed. And so we've been very fortunate that from the beginning, and our founding president is here tonight, that we decided early on to be strategic and really think about what the needs were of the community. We used to do the community needs assessments because there weren't nobody else was doing community needs assessments. And so for many years we funded access to healthcare projects, a lot of transportation. We still continue. It's one of our sustaining grants. We still, for 20 years, have been supporting local transportation services. For nearly 20 years, we've been providing free screenings, cleanings, and sealants in the schools for our prevention, for oral health prevention, and then our others. We do some prescription assistance programs. Those are our long-term programs. Actually during COVID, we decided to do a strategic planning process, and we really looked inside and thought, what could we do better? And what we decided to do is change our focus. Instead of funding programs, we actually are working very closely with all our nonprofits, and we provide capacity building, leadership support, and funds to improve community assets, whether it's a community health center or we've worked with libraries, we work with third spaces to try and create places for people to engage. But we really mostly work with our local nonprofit groups to try and keep them healthy and resilient. We really do believe that with a strong nonprofit community and network, that our community will be healthier and safer. And so we spend a lot of time on that. The third branch of our priorities or strategies is to support local decision-making. And the most that we've done in that area, because it's a new area for us, has been around housing. So we support heavily the Litchfield County Center for Housing Opportunities with general operating support, but we also have funded a lot of community engagement activities with all the local housing organizations, and we've even started a revolving loan fund for the housing, affordable housing associations to be able to buy properties that go on sale with some speed rather than having to wait to get the state funding to buy it. We will provide bridge loan funding for that. So, so we really are trying to support more of the social determinants of health directly, and it's been very rewarding, I have to say. I've been there for 21 years. So, as far as Sharon Hospital, from the beginning, Jim's here. We've always worked together. We did a lot of health fairs in the beginning and a lot of programming together. And I've participated on the Community Needs Assessment Board for the last couple of phases of whoever owned the hospital as a community member, and I think my main resource for that is to provide the hospital's leadership with understanding about what I know about the community, because I've been around a long time and I do know most of the nonprofit providers in the community. So I don't know if I answered that, but that's what we do. So, we're getting close to the end here. This question I thought was actually interesting. What can this audience do to help you? And I think that leads us back to that, well, we call it local decision making, but we're also thinking about how we can do more active advocacy. And so I look to expertise here to provide me with ideas and information so that we, as the Foundation for Community Health, we're a public charity, we are allowed to express our opinions, can share with the state and others what we think needs to happen. So I don't know if Joanne, you have any more specific action?
Yeah, I mean, I think we talked about that the power is in numbers. As long as you understand and are aware what you are supporting, we'd love your support. We do try to get communication out. We try to advocate. I am at the Capitol at least 2 to 3 times a week. The last several weeks have been a lot of testifying and Health and Human Services bill and Appropriation Committee fighting for those Medicaid rates. And again, we're grateful that we have the support of the delegation that we have in the Northwest Corner. We've been really grateful to them to help us support. But I think as an audience, strength in numbers and power in voices. And so when it comes to advocacy, your help is greatly appreciated. You know, so money is greatly appreciated too.
I'm sure that's true for everyone.
Yeah, it's true for everyone, right? And Medicaid reimbursements, unfortunately, unless we advocate together and you support that purpose, hopefully it will happen. And I think, you know, again, with the support we have from delegation, that will get a little closer. And so but in all, you know, what we are doing this coming year, again, the community assessment needs has been done. We are trying to get ourselves out there as a new neighbor and friend. We have a Betty, and in case I forgot to mention that earlier, Betty is our mobile medical unit. So it means bringing exceptional treatment to you and doing things like going out to those homebound patients or providing care when someone can't leave the house, or going to health fairs to the Touch a Truck events for the kids and things of that nature. So I think the best support that can come from you is to believe in what we do and to help support us moving forward, to help support all of you.
Yeah, I'd like to add a couple of things. One, educate yourself. Make sure you have accurate information so that you can be an appropriate advocate. 2, share your perspective with us. When we send out surveys like our Community Health Needs Assessment, take it, because we really want to hear from you. That's how we design our strategy and our approach to treat the community. So the more that you participate, share your voice, and are educated, the stronger advocate you could be.
Yeah, I would have to agree with all the following. And the other thing that I think is huge within this community is educate yourself. I can't tell you how many phone calls I've received of people saying, I don't need your services, but I need your help. And I congratulate them because it's an overwhelming experience. And know your contacts. Don't be afraid to reach out. Don't be afraid to learn what there is in this community that can help you. And don't be afraid to show up to these events that, you know, are funded by organizations such as us, just as a level of support. So definitely, you know, just know your options. The other quick thing I think I should add, and this is me educating you, but you know, which I hope none of you get here, but if you ever need services such as the VNA, one of the biggest issues that we are seeing is that a lot of these hospitals are, not Sharon, are referring VNAs just by their choice. And just know for yourself, you have a right of choice. If you want to go with a VNA such as Visiting Nurse and Hospice of Litchfield County, you have permission to say that, and they have to send the referral there. Many of them are referring the bigger corporations, and it's really scary for us because, you know, we want to help, and that's how we're going to stay alive. So just know for yourself that you have options and tell others.
I would just add to pick up what Megan was saying is that we need all of these organizations in order to deliver rural healthcare out here. It requires a network, a resilient, flexible network that includes a health system, you know, visiting nurses and an FQHC and other nonprofit providers. We need them all. And so echoing, you know, education is really important, and understanding that we need to support all of these institutions and keep them vibrant.
Is there anything that we can do for the legislature in particular?
Well, I love it when Joanne comes and testifies. So. Anytime any of you, I mean, I always appreciate, so one of the things, you know, Connecticut is pejoratively, you know, land of steady habits. We're slow to change in a lot of ways. The pandemic did finally at least allow people to testify remotely, which means that people from the Northwest Corner actually can show up and testify and not have to take an entire day off work and sit around the Capitol, as lovely as it is, waiting to have your number called to show up. You can testify virtually via Zoom. We do listen, we read your testimony. It is important to have you show up when we have these kinds of bills that affect rural health. So, you know, communicate with these, sign up with these organizations, and, you know, when there's an issue that's important, you know, sign up and testify for just 3 minutes. That's all it takes. We need your voices.
I'm going to vouch for Maria saying they listened. The last testimony we did, we had 335 people registered to testify. I was number 200 and something. So I went home and used the remote option. I was there, and then I figured, oh, that's going to mean sometime really late. So I went home, and the committee listened until almost 1 o'clock in the morning and allowed everybody's name that was on that list to testify and be heard. And so I am really grateful for that, and that's what I mean by voices are powerful, because they do listen, and we have seen effective change from being able to testify. But kudos to whoever did stay up till 1 o'clock in the morning, but they did, because they wanted everyone who had something to say to be heard. So I did want to validate.
It's been recently brought to my attention that Connecticut's kind of unusual that we do that. Not all states do that, allow that kind of public testimony. And I will say, as a committee chair for the last 6 years, that's really important to me. You know, I want to hear what people think about the stuff that that will have impact on your lives, and people from all walks of life, and it matters. So,
well, I do think now more than ever people need to be engaged.
Yes.
So, thank you for the question. Thank you to the great panel, and I hope you have a nice evening.
Thanks to Salisbury Forum.